again, I'd like to warmly welcome Professor Majid for taking time out of his busy schedule to attend this meeting. And he's the main speaker for today. My own job is to introduce the topic and give a background as per our experience with pancreatic cancers in Nigeria. And this is quite important, especially with the COVID-19 era we're dealing with. So this is the topic we're talking about. I'm going to highlight mainly the cause, the care, and challenges in the COVID-19 era. And so I'm not going to go through the whole gamut of material on pancreatic cancer because we'll not have the time to do that. I don't want to bore us. So I'll just highlight some things that can generate discussion later on. I do not have any disclosures. So I will follow these highlights, this outline. I'll talk about some case presentations. I'll highlight mainly some issues about cause, clinical presentation, care and challenges, and then some COVID-19 peculiarities, and then conclude and hand over to Professor Majid. So again, the pancreas is a very interesting organ, and it's quite difficult to treat because it lies closer to the back and the front. And so many of the symptoms are hidden until quite late in presentation. And then it's surrounded by so many vital organs, like the duodenum, the common bile duct, and the like, so that initially when a patient presents with complaints of pancreatic disease, usually misdiagnosed as being from any of these related structures. So it's quite important for us to be able to understand that this may be a condition that a patient may have when he presents with upper abdominal symptoms. So quickly for the case presentations. So we have a 48-year-old male who had epigastric pain of multiple pruritus, dark colored urine, pale stools, with lots of appetite and then loss of weight. And unfortunately, this patient had been treated for Helicobacter pylori on account of pituitary PUD for almost 6 months during the onset of the disease. And he did not have any other form of investigation, save for an ultrasound scan that seems to suggest peptic disease, which was quite surprising. And then the patient was referred to see a surgical oncologist because of progressive projectile and vomiting. And with the CT scan that showed that he had obstructive jaundice from pancreatic tumor with liver metastasis. So when the patient was seen, he was chronically ill, he was pale, he was icteric, and he had epigastric mass with hepatomegaly and enlarged gallbladder. His clotting profile and liver function range and bilirubin was sky high, 25 milligrams per deciliter. And so he was optimized, following which he had a palliative bypass procedure and a pancreatic and liver biopsy. And surprisingly, he did quite well and he was discharged after a week. And he's currently has received 3 cycles of palliative gemcitabine and Xeloda chemotherapy. A second patient, a 16-year-old Nigerian female who was seen in a teaching hospital in Nigeria with an abdominal pain of 7 months duration. And she had a vague left upper quadrant fullness on physical examination. And there were no other significant findings on examination. Her lab workup was normal, but she had a record CT scan done, which showed that she had a cystic mass in the pancreas, and that was reported as a pancreatic pseudocyst involving the body and the tail, and it was measured as 10 by 9 by 8 centimeters. This is the cyst on the pancreas. But at surgery, we found out that there were some suspicious features of the cyst. There was very limited mobility. There was a lot of neovascularization on the cyst, and we saw lymph nodes. And so we were quite worried that this could actually not be a pancreatic pseudocyst. Now, our standard treatment for pancreatic pseudocyst usually involves what is called a cystogastrectomy, where we connect the cyst to the stomach to allow for drainage. But with this setting of possible malignancy, and we do not have facilities for frozen section, we decided to proceed to do a central pancreatectomy. So we excised the cyst and the body of the pancreas end blocked, and we're able to put internal drains and close up the pancreatic stump. And we also put the bolt interposed in between the infected specimen. Now, this is the excised specimen of the cyst itself. And she developed a type A pancreatic fistula on the 3rd day post-op, which resolved on octreotide therapy, and she was discharged on the 8th day post-operatively. The study came out as a malignant tumor of the endocrine pancreas, and the immunochemistry was positive for synaptophysin and chromatography, and definitely we felt that this patient had a cystic pancreatic neuroendocrine tumor, for which she's currently being managed for. The final case presentation is a 54-year-old female who had presented with jaundice of 2 weeks duration that started itching and dark urine. Now, she was referred for ERCP on account of suspected common bile duct stones that were reported on CT scan from the referring hospital. But when we reviewed the images the patient came with, the patient actually had a double duct sign. That means that the pancreatic duct and the common bile duct were both dilated. And this, in terms of the risk factors, I'm trying to talk about that: older age, male gender, African race, and cigarette smoking, diabetes mellitus, obesity, and chronic pancreatitis have been considered to be some of the major risk factors in terms of pancreatic cancer. And it's also been possible that exposure to environmental factors such as pesticides, some pesticides can actually predispose to pancreatic cancer. Of course, there's a genetic basis towards it. And when we see a young patient having pancreatic cancer, there's a possibility that this patient may have some underlying genetic disorder that is predisposed to early onset of the tumor. Especially there are other tumors possessing the same patient. The clinical manifestation of pancreatic cancer actually depends on the location of the tumor and the extent of the disease. Tumors that arise from the head and the neck usually tend to cause biliary obstruction. Those that arise from the body or the tail may not present with obstructive features, but may cause local infiltration and may be quite advanced when they are diagnosed. And that's one of the reasons why there's some reason of delay in manifestation of these patients when they come to our hospitals, because they tend to attribute their symptoms to other conditions, upper GI conditions. Again, for parents who have advanced disease where there's systemic spread, they may have features of liver metastasis, pulmonary metastasis. And when there are symptoms, usually a sign that there's either local or distant advancement of the condition, and it's difficult to treat at that stage. It's only if the timeline is usually in a very short period, like the last patient that was presented, that it's possible that the patient may have some fairly early presentation and may be unable to cure. Now, unfortunately, again, like I've mentioned, this condition is usually misdiagnosed, and people are treated for many other conditions like pelvic ulcer disease more commonly before the clear-cut telltale signs and symptoms are present, in which is almost too late. Now, again, in terms of patients, most of our patients come in with some form of ultrasound scan or the like, but I feel strongly, in my own personal opinion, that if a patient has upper GI symptoms persisting after medical treatment, the patient requires to have an upper GI endoscopy or some form of endoscopy and an abdominal CT scan as a minimum, because many patients are treated based on ultrasound scan that don't have high sensitivity and specificity, and ultimately the patients have a delay in their presentation to the appropriate sector. Again, in Nigeria, we have issues with getting access to MRIs, MRCPs, and PET CT scans. I think that's a decision later down the line. Again, we need to do laboratory investigations for these patients. Liver function test is quite important, renal function test and the like. And like I mentioned before, endoscopy is quite important. Again, in this era of COVID-19, there's this discouragement against doing elective endoscopies for patients, and that's going to factor an issue in the delay of diagnosis, because endoscopies can be a very good means of transmitting coronavirus from patients to clinician. And that's why many people have actually stopped doing endoscopies in our setting because of the coronavirus pandemic. Of course, if the patient has other comorbidities, we have to check for ECG and echo and the like. And so these are some of the investigations that we tend to do for our patients. Now, in terms of the care of the patient, surgery is the mainstay of management of our patients. And what actually ensures long-term survivorship is being able to resect the tumor. And so, unfortunately, most of our patients come in when they are far advanced in disease, and all we can do is to find a way to relieve the obstruction. So if there's an obstruction of the bile ducts, we do a bypass of the biliary system. If there's an obstruction of the stomach or the duodenum, we bypass that obstruction too. And so it's quite difficult when you see a patient who has been seeing other physicians for a long period of time and comes to you without having the opportunity to have appropriate surgical excision. And doing a bypass is mainly of a palliative nature. Again, to be able to determine which patients will actually be able to get resection, there is this issue of knowing whether the patient is actually resectable, unresectable, or borderline resectability. Again, these are questions I don't want to bore with the details, but those are things that surgeons consider when making a decision in terms of resection. Now, chemotherapy has an important role too. For parents who have far advanced disease, maybe borderline resectable disease, where you are not sure that the tumor can be resected at the first sitting because of invasion of vascular structures, for example, you could give chemotherapy ahead of surgery to reduce the size. And then ultimately, when there is evidence of tumor shrinkage, you can now plan towards doing a major resection. And adjuvant therapy is also one of the modalities of giving chemotherapy, because what possibly causes death in the patient is not mainly the local disease if it was resected, but the systemic metastasis. So when you give chemotherapy after surgery, the aim is to kill any micrometastases that are spread to other parts of the body. And these are issues that we need to consider. Unfortunately, many of our patients come in with stage 4 disease, where when you give chemotherapy, it's mainly with the aim of trying to palliate or control disease and not with the hope of cure. And that's another modality of giving chemotherapy. Now, I know in the States, they will tend to incorporate radiotherapy as part of their treatment for these patients. But personally, the morbidity is quite severe, and we don't have ready access to radiotherapy in our country. And so chemoradiotherapy for pancreatic cancer is not really a popular choice of treatment in Nigeria. Of course, there are many molecular and targeted therapies that are coming up that can be used to treat this kind of patients. Now, our challenges in Nigeria, I've mentioned over and over again that there's this issue of misdiagnosis and delayed diagnosis. So patients get to be labeled for the wrong condition for a long period of time, or the diagnosis is delayed until it's almost too late. And that's why we see many of our patients coming with stage 3 and stage 4 disease. Or there's also this issue of infrastructure deficits. So we have patients, so we may have patients coming early, but the facilities to do an appropriate resection, the facility to appropriately stage the patient, the facility to properly mind the patient after the surgery in terms of ICU care is not available. And that's why there's a lot of medical tourism occurring in our country. Now, again, we need to develop the skill and expertise in pancreatic resections, in ERCPs, interventional radiology. It's not a one-man show. Lots of people have to be involved in treating this kind of patients. Unfortunately, many of these specialties are quite lacking in our environment. I know that we've tried to form a society of pancreatic cancer surgeons in Nigeria. That happened in January this year, and we're hoping that with time there will be skill development to increase the number of sessions we are doing in our country. The discussion on the typical experience of a major Nigerian teaching hospital. I think one of the largest series we have available in Nigeria is from the IFE group, led by Professor Olusegun Alatishe, where they had two papers published on this issue of pancreatic cancer in management in a low resource environment. Now, the first paper they presented was in the early years, where between 1988 and 2007, where over an 8-year period, they saw 96 patients. And of those number, just a little over half were actually fit for surgery. So the majority of the patients were actually unfit for surgery and eventually died of their disease. And of those who had surgery, only 2% had the pancreatic resection. So the pancreatic resection rate was quite low in that line. And majority of the patients actually had a double or a triple bypass. And the Brown technique, which is familiar to many of the surgeons here, was the preferred approach rather than the Roux-en-Y procedure. And ultimately, the median survival for this patient was not surprisingly low, because many of the patients survived just 3 or 5 months after the surgery, because they only had bypass procedures. So again, even though this was a study that was over a long period of time, and it's probably quite antidated now, this is still the typical setting we see in many Nigerian teaching hospitals, where majority of the patients who come with pancreatic cancer are actually unfit for surgery, and those who actually eventually have surgery, very small fractions, small number, are able to have their tumor removed, and majority eventually just have a bypass, so leave the obstruction that they may have. And because the tumor is still present, they eventually die within a year or within 6 months of surgery. So the study hasn't been really beneficial for our patients. Now, this is still a similar experience to what we see in our own setting, another setting in Lorraine, where again, majority of the patients have bypass procedures, and the child score for these patients were quite high. Many of them have child B or child C grade. So these patients are actually poor candidates for surgery. Now, the IFE group have a more recent paper where they opened up a collaboration with some centers in the United States of America. And based on this collaboration and skill transfer and acquisition, they're able to have improved results. So first of all, they were having more patients coming, 170 patients within 7 years, an average of 2 months, 2 patients per month with pancreatic cancers. And of these patients who came in, 21 of them actually had pancreatic resection to the previous studies. Again, they had a mortality rate of 14.3% and a morbidity rate of almost 25%. And a significant proportion of patients have fistulas, which is a major issue after the surgery, where the pancreas begins to leak after the surgery. Now, the overall survival actually improved in these patients to over a year. So many patients live between 13 months and 84 months, compared to the previous series where the survivorship was between 3 and 5 months. And ERCP now became more available in that setting. So it shows that if we're able to improve the referral pattern of system, getting patients to come in earlier and having their tumors removed, there's a high chance that they could have long-term survivorship compared to what we're experiencing now. Now, I'm almost done. Just quickly want to mention some co-related cancer systems with pancreatic cancer before I hand over to Professor Majid. So again, this issue of washing our hands and wearing a mask and washing our space in WWs is quite important. There's no point politicizing it. This is going to help in mitigating the spread of the virus. And again, the underlying feature is to make sure that we treat this kind of patients who have cancers in areas where there's very little COVID-19 infection. Unfortunately, in Nigeria, we are still having increasing incidence of COVID-19 infection, and the numbers keep rising. As at last count now, we had over 13,000 cases, and more patients are probably not getting recorded. And so this is a source of concern for us, because the patient who has cancer and who has COVID-19 infection is at risk of mortality. And so most of the time we try to avoid doing this kind of patient surgery in areas where they have active COVID-19 infection. We call them the hot hospitals. Again, we've been trying to avoid face-to-face outpatient consultation as much as possible, and to restrict it to telemedicine until just before surgery, when the patient can have the face-to-face consultation with the doctors. And again, we're doing a lot of restriction and telemedicine outside the traditional norm of face-to-face contacts. And social spacing has now become the norm in it. One issue we have to consider is the fact that we have so many patients who need surgeries, and so many patients had their surgeries cancelled because of the lockdown that occurred over the last couple of months. So we need to find out, how do we prioritize our patients? How do we know which patients are vulnerable and may succumb to our surgeries? And we have to create the right environment to treat this kind of patients. So this is one issue that we really need to consider. Already in our clinics, what we devise is that if a patient comes in with cancer, that patient takes priority over other patients. The next category of patients who come in are patients who have had benign conditions, but their conditions were postponed or rescheduled because of the lockdown. And then the last category are those patients who come in freshly with a benign condition. They have to wait their time. So we try to find a way in which we put priority in the cases. But again, even among the cancer cases, we have to find out who has to take priority, because there are still restricted cancer systems available for managing these patients. So the issue of surgical priority is important. Again, because of COVID-19, we've had to adjust or modify the way in which we prepare the patients for surgery. Now, the recommended pathway is I recommend that the patient have some self-isolation for at least 2 weeks before the procedure. Now, this probably may be very difficult to implement or to observe, but that's the recommended guideline. The patient should be asymptomatic at least minimum of 14 days before the procedure, and should have isolated yourself, and should get the RCT COVID-19 test done a day or two before the procedure. Again, this is a very big issue. In reality, many patients wait for a week, 2 weeks, 3 weeks before they can even get the coronavirus test and RCT results. And so this is an issue that we have to address. Again, the recommended pattern is to have a chest CT on the day of surgery to be sure that the patient does not have any pulmonary infiltrates. Again, many patients cannot afford a chest CT scan, and the urologists are quite unhappy about having extra burden of going to do a chest CT scan when they're already almost overwhelmed, and then the patient has surgery. So what we tend to do is that we follow clinical guidelines. We have a checklist of symptoms that we find out from the patient. If the patient has had any of these things, we let it last 14 days. And then if we cannot get a swab done, we cannot do a chest X-ray. Chest CT scan, we do a chest X-ray at least as a minimum. It's not the best. And then we are ensure that the patient, that all the healthcare providers have some basic form of PPE when they encounter these patients. Because in the absence of all of this, we cannot verify whether the patient can actually has asymptomatic coronavirus infection or not. So these are issues that we have to consider. And ultimately, we have to minimize the number of days the patient spends on admission. So the enhanced recovery after surgery, or the ERAS protocol, is what we also tend to subscribe to. And then when the patient is discharged, we usually prefer the patient doesn't get exposed to members of the community. So the patient should self-isolate, and because also there's an environment where COVID-19 virus can be acquired. And we tend to favor telemedicine if possible in terms of patient follow-up. If there has to be clinic visits, then they have to be scheduled and for specific reasons. So this is a cancer pathway that has been recommended for surgeries in our patients here. How applicable this is to our environment is now left to see, because there are a lot of bottlenecks along the way. Again, we have a special consent now for COVID-19 infection. We tell the patient that they can acquire COVID-19 during their surgeries or during their care and stay. And this is another issue that is now new based on this era. Of course, the consent and risk assessment is very, very important for our patients. Now, there are a lot of guidelines, recommendations being brought up by many colleges, both within the continent and outside Africa. And there are lots of things that are in there. But what I just want to emphasize is the fact that the recommendation to have PPE for all our surgeries is very essential. Having N95 masks, face shields, and all that precautions in terms of protecting healthcare workers from having the infection. Now, again, I've talked about the issue of priority, how we have to prioritize our patients so that we know who will benefit the best from these surgeries. Ultimately, for patients who have hepatic, biliary, or pancreatic surgeries, in the scale of preference, most people now recommend that pancreatic cancers probably take a highest precedence because there's an urgency in trying to resect it. Resecting the tumor will give a higher chance of cure in the patient, and they'll have the best benefit of survivorship. So pancreatic cancers form the majority of the patients who we have as the people that will put high in the scale of preference. So that means that patients who have cholangiocarcinomas, liver cancers with metastasis, those conditions that can be treated with medical treatment and therapies, we tend to put them further down the line. I'm almost done. So this issue of chemotherapy is also another problem too, because we know that patients who have coronavirus and get chemotherapy may eventually succumb to the disease, and there's a potentially high mortality rate. And so we try to recommend that if it's possible, the patients have oral chemotherapy rather than injectable chemotherapies, and that also reduces the number of hospital stays that patient needs to have. So these are some of the things that need to be modified in our patients. So in conclusion, we again need to remind ourselves that pancreatic cancer is a deadly disease and it requires early detection and prompt treatment. In low-middle income countries like Nigeria, there's this issue of delayed or misdiagnosis. We have socioeconomic challenges. We have a weak healthcare system, which are major obstacles in treating these patients. And in the era of COVID-19, we've had some new unique challenges. It will be very interesting to hear what Professor Mahdi wants to say concerning their experience in Pakistan in treating these patients. So I'd like to thank you for the audience.
Thank you very much. I was got muted. I couldn't unmute myself. Thank you so much. And thank you again, Dr. Adiye, and a wonderful, wonderful presentation. I think you have summed up everything, and a lot of things I was going to say, you've already said them. I think that there are a lot of similarities between the system in Pakistan and how things work, and in your country also. So I think, and I'm really grateful for you because you presented the second case number 2, about making a mistake about thinking that cystic neoplasm of the pancreas is actually a pseudocyst. I'm going to touch that also because that's a very important subject here and big problem. So I think I'm going to share my screen now, and just give me a moment. As soon as I have things out of the way. Okay, just a brief introduction. I am basically an old battle axe from the previous century, a traditional general surgeon trained in Pakistan and overseas also, and I've been doing a lot of cancer surgery. And I have a strong association with the surgical oncology of Society of Pakistan. And I'm heading the general surgery department at Sheikh Zayed Hospital, which has recently been upgraded to the surgical oncology department. Traditionally, for the last 20 or 30 years in my hospital, we've been doing a lot of surgical oncology, cancer surgery, but things were not really organized. It was only last year, about a year back, that we started to organize things, and for the reasons that I'm going to show you just now. So that's the hospital where I work. And now, because so much cancer shows up at our hospital, we have got one totally dedicated cancer hospital in Lahore, which is my city, and which takes all the cancer patients. And everybody with the label of cancer tries to go to that hospital, but that's a small hospital. They can't entertain so many patients. So subject to their selection criteria, most of the patients bounce off and they end up at our hospital, which is the next station. So we started looking at the burden of our cancer. If you can see the pie chart, the vast majority of cancers that we see are either breast or colorectal. And for that, for the reason higher volume, we have started dedicated colorectal and breast clinics for the past 1 year till the pandemic showed up. Gastroesophageal cancers takes the next, and pancreatic cancers are also significantly there because you see, being I'm one general surgery unit, there's another general surgery unit who shares the same volume and type of cancer, and we have a dedicated hepatopancreaticobiliary and liver transplant unit in our hospital who are taking a larger volume of cases. So on the average, my unit or myself, I do about 9 to 11 pancreatic resections per year. So last year, this is data only from the last 1 year. During that time, I was traveling also. Maybe I missed 1 or 2 cases, but we did 9 pancreatic resections at that time. So we are looking at for the development of our cancer program, we were looking at the burden of disease. The second thing was, as Dr. Adeyeye pointed out, which is very similar, is the stage of the disease. Now, the stage of we have seen that most of the cases, that vast majority of the cases that show up with us are advanced cases. All cancers, especially pancreatic cancer, it's upstage disease, and we see our cancers in a younger age group. Somehow, the cancers that you see in the aging or over 60 population in the Western or civilized world, in our part of the world, we don't know why, but we see them at a younger age group. We've got financial and economic constraints here, very severe ones, and that the things would go on like that. So this is okay. Thank you. So this is just the pancreatic cases from pancreatic cancer cases from the last year 2019. So you can see that on the left side, these are the pancreatic resections that were done. And these were a total of 9, as I already told you. 7 pancreatic duodenectomies were done last year, and 2 distal pancreatectomies for cancers was done. However, 2 enterobiliary bypasses, like the triple bypass that Dr. Adeyeye was describing, were also done. But we only now do a triple bypass or a surgical bypass in those patients who cannot or who fail to have an ERCP or a percutaneous transhepatic biliary stent. So generally, we have found that as the expected life survival with a permanent metallic or a plastic stent is the same as with the surgical bypass, so we prefer the endoscopic or percutaneous stenting under imaging. So only 2 biliary bypasses were done last year, and these 9 patients had resections. And there were 2, incidentally, just out of interest, 2 pancreatic resections were also done along with gastric cancer, because that was advanced gastric tumors. You see the advanced nature of the disease over here, that 2 distal pancreatectomies were also performed. The rest of the patients, we don't have, you see this question mark here, we don't have exact data, some come and go, however, poor follow-ups. 13 patients had plastic biliary stents in the hope that they may be helped with neoadjuvant chemotherapy or neoadjuvant therapies, and they may be able to, we may be able to offer them resections later on. And 5 patients last year had permanent metallic stents. We just gave up on them, and we're happy to get away with metallic stents. So our problems, very, very similar to problems in Nigeria, I think is our biggest problem was little authentic data. We didn't know what was actually happening. And of course, time from presentation to definitive treatment. Now, a breast cancer patient, from first touching the hospital and diagnosis, by the time of definitive therapy, it takes up to 3 months to get to treatment. We have now, because of the new system, tried to shorten that period, and we are going to have audits on this, and we are already doing that. The time has to be reduced to 21 days or less. And communication failure adds to this. Now, weak follow-ups, missing links, and disappearing patients. What are the disappearing patients? Disappearing patients, very, very common in our culture, is say somebody with deep jaundice, or say a borderline resectable cancer. You either resectable and you want to lower the bilirubin to safer limits, you get an ERCP temporary plastic stent done to lower the bilirubin, or you want to do neoadjuvant chemotherapy. Once their jaundice comes down, they think they are cured. They think that the disease is gone, and you send them for neoadjuvant chemotherapy, they're definitely going to go missing. 1 out of or 2 out of 10 patients will come back. The rest will go missing. So, and they will then come back 6 months or 8 months down the line when they have metastasis or they are beyond surgical help. So that's a big, big problem, right? Okay. So the last but not the least is been the failure to follow standard guidelines. There have been no local guidelines, and there have been haphazard single man decisions which have led to, unknown results, and then there is no data. Okay, so what we did quickly was that we decided, I represent the Surgical Oncology Society of Pakistan as the president, and we have the Society of Surgeons of Pakistan also. Previously, I've been associated as the vice president there. And we have collaborated to formulate guidelines for various cancers, including pancreatic cancer, because now it's not as common, so it's less on the priority list for guideline development, but we're developing our own guidelines. Also, collection of outcome data. You do a beautiful Whipple's operation, you replace the portal vein, or one of my colleagues 1 month back replaced the inferior vena cava also with a synthetic graft while doing a pancreatic odontectomy, excellent resection, but we don't have data. We don't know what happens to them 6 months down the line or 10 months down the line. So for the last 1 year, we are keeping stringent data, and hopefully in the next 2 or 3 years, we can come out with some publications which will help our own country and other countries who are developing surgical oncology programs. And multidisciplinary team management. No one man treats cancer these days. It's not Dr. Harun Javed Majid, professor, the hero, who treats cancer. It has to be 11 people. It has to be a multidisciplinary team. So many minds taking correct decisions, evidence-based decisions, safe decisions in the best interest of the patients, right? So we have developed our multidisciplinary teams. In the pandemic times, we are continuing on WhatsApp and on Zoom, but no patient goes to the operation theater now, no cancer patient without having a decision being taken in the multidisciplinary meeting. And of course, mortality and morbidity meetings and clinical audits are very, very important, because the idea is to improve. The idea is not to, accuse somebody or humiliate anyone. The idea is to improve, and improve what? Healthcare. So unless you look at your mistakes and mortality and morbidity, you can't improve. You've got to have regular audits. And last but not the least, the continuing medical education. And you can't achieve anything unless you've got well-trained teams, unless you've got well-trained surgeons, unless you've got experts there. And they need regular training programs. I'm so happy that now the College of Physicians of Surgeons of Pakistan has introduced the new fellowship in surgical oncology. A couple of fellows have already come out. And I remember at least 7 people I met in Holland last year, when they had all Pakistani people who had passed the exam, in the surgical oncology fellowship exam in Europe. So we are getting new blood, we are getting new well-trained people, and this has to continue. We've got to have well-trained surgeons. And then we were doing all this. What happens? The pandemic comes. Everybody's horrified. Initially, we didn't bother for the first 2 or 3 months. But when it showed up over here, everybody was, I wouldn't say scared, because my surgical teams, my residents, they're all fearless, brave people. But they were scared of, damaging or, putting their patients at risk of this unpredictable virus. How you don't know how this virus is going to behave. So severe in some people and mild symptoms in some, and you may be asymptomatic carriers. So my doctors were afraid, not for themselves, but for taking this disease home to their parents, to their families. So this put us on a very, very negative sort of a gear. But with well motivated and energetic teams, you can get away. This is just quick figures from yesterday, that the total number of cases in Pakistan, and we have about 5,522 deaths. And although we had predicted some time back that we would reach during the acceleration phase, we'd reach the peak of the epidemic in somewhere in August. According to this diagram, if you see it, we predicted in June that this would be, the peak would be somewhere in August. But as you can see, This is the daily cases. We are here now. Things have officially gone down. We don't know what's actually happening. People are reporting, maybe lesser people are coming in for tests. Lesser people, even though sick, are reporting to hospitals. And you see that, but you see, mortalities cannot be hidden. At least there are fewer mortalities, as you can see over here. But what's going to happen soon? The holy month of holy festival of Eid is arriving soon, and people are going to get together again. Maybe there's another spike. We are preparing for that. Having said that, even though things may be looking better on graphs, but I don't think that we can become careless or start taking our masks off, or become indiscriminate about surgery. We've got to continue all barrier precautions, and all guidelines need to be still followed. Dr. Adiyaya just showed us the guidelines from the intercollegiate guidelines from the Royal College of Surgeons of England, Scotland, and Ireland, which we are also following, and our guidelines that we have developed, I'll just show you a little bit, are based on those. Right. So I won't linger too much on this, because these guidelines are very, very similar to your own Nigerian guidelines. The only thing is that we decided in the beginning of the pandemic that we will stop all hyper elective or super elective procedures. Only those which were needed, either trauma, emergency surgery, or cancer. Cancer cannot be stopped, especially cancers which are complicated by bleeding, obstruction, and perforation, and cancers in which delay in surgery will adversely affect the outcome. And that includes pancreatic cancer. We cannot delay it too much. There are some international European guidelines which say that you can do a stent, you can do a neoadjuvant chemotherapy regimen, and you could maybe tie it over for about 89 days to about 90 days. But in Pakistan, where leaving surgical facilities aside, even the adjuvant therapy facilities have been severely affected. So you're not sure, you're putting a stent and sending somebody away for 3 months, and is he going to get a neoadjuvant or not? Or what kind of neoadjuvant is he going to get? There are cost issues. They can't get first-line therapies. They can't get the therapies which will work because it costs so much. They will get the 20-year-old therapies probably, and which will not work, and they will come back with advanced disease, or they will not come back at all. So it's just cancer and emergency surgeries for now. And but consider COVID-19 infection possible in every patient. Even though the Pakistani graphs and statistics may be going down, don't be too happy. I know some of my Pakistani colleagues are here. I hope my liver transplant surgeon is also here. I invited him. We have to continue taking precautions, even though things may seem much better. It's best to be careful. Okay. So not going into details, every patient, cancer patient, comes in through a triage clearance, and at least 48 to 72 hours before surgery with some home isolation. And we get a COVID test done. We don't trust that because many of the patients are not actually taking care at home. So we want to do the test closer to the admission and then keep them in a separate area of the hospital. And we have consent to repeat the COVID PCR in our own hospital, because that's a free government facility for that particular test. So we may repeat it, and like Dr. Adi's special consent form, we have special consent forms also. So I think it's no point spending time on PPE because we were talking about pancreatic cancer, but because we are talking about pancreatic cancer and we do diagnostic laparoscopies for pancreatic cancer also, and laparoscopic HPB surgery is also done. We have done no laparoscopic procedures during the pandemic. We have stopped our laparoscopic procedures because we have no negative suction, negative ventilation operation theaters, and we do not have facility to have safety for that. Regarding the COVID positive cases, we have declared our hospital a category green hospital. A category green hospital is like your cold hospital. We are trying our best not to let the COVID in. But despite all factors, one of my surgical residents from the Department of Surgery and Surgical Oncology, 3 nurses and a receptionist, they became COVID positive. We caught them earlier on, segregated them, and we have not seen morbidity or a mortality in any of our cancer patients yet in the last 4 months because of COVID. So we're category green, hopefully, but sometimes, just a flicker of red or orange shows up. We try to control it. all COVID cases which are detected positive before surgery are referred to the local government hospitals, which are dedicated COVID centers and also take care of cancer. And we only retain those COVID cases who, if we have, say, done a major resection on them or operated on them and they turn out to be COVID positive later on. So then we retain them in our own hospital. We have a separate wing for those. Or we have that separate wing for our own teams who get COVID positive. So this is data for the last 4 months, March 2020 onwards. The operations that we did on the left, we did 2 pancreaticoduodenectomies only for in the last 4 months for head cancers, and we did 1 distal pancreatectomy for pancreatic cancer. So it's a total of 3 resections in the last 4 months and 1 triple bypass, because that was a patient with advanced disease and we'd asked for a permanent metallic stent and they couldn't get it in. So we went in for a surgical triple bypass. By the way, for a triple bypass for the surgeon, we prefer not the cholecystodegenostomy. We do a choledocogenostomy, Roux-en-Y type, or we do a hepatocogenostomy, or at times a palliative bypass with the left duct may be done. And these are the patients. Again, there are no exact figures here, but there were at least 12 patients which were deferred or which were refused surgery, and they were referred either for neoadjuvant therapy or for palliative adjuvant therapies. And some of them, 4 of them, had temporary plastic stents, because we have hopes that if they come back after neoadjuvant successful downstage, we may still be able to operate on them. If we can't, we replace the plastic stents with the metallic stents. And 2 patients got definitive permanent metallic stents. So that's the data. 4 major resections, 1 bypass. The rest of them got stents or were sent for neoadjuvant. Okay, now this is one case that I wanted to show you. One male patient that we had, and he had more than borderline resectable disease. As you can notice over here, that the pancreatic body and tail tumor, there it is. It's also involving the main trunk of the superior mesenteric artery and its terminal branches. And that's the superior mesenteric artery, again, red arrow over here. And you can see that the whole tumor is into the hilum of the kidney. Now, this chap had a couple of opinions, and the crust of the diaphragm is also held pretty irresectable, I think. But you know, in Pakistan, we sometimes take on to more than borderline resectable cases. So we've extended the boundary a little bit. But in this particular patient, because of the involvement of the superior mesenteric artery, he was not offered surgery. He was even ready to sacrifice his left kidney. He said, remove my kidney also, but remove this tumor. But it could not be removed. And as he was not jaundiced, you see, this is a pancreatic body tumor. For the people who are not doctors, we always say to my friends and colleagues that screams for help from the body and tail of the pancreas reach the outside very late, just like esophageal cancer lying in the posterior mediastinum. Because the patient with the body and tail tumor does not get jaundice early on. The head tumor, the periimpulries and the pancreatic head cancers get jaundice earlier on, and they get caught by that, and they are treated earlier. Vast majority of the body and tail tumors have a worse prognosis, not because of biology only, but because of late diagnosis and late presentation. There is no jaundice. So this gentleman was pretty well preserved, ECOG 0 or 1. And despite that, we had to regret to him, and we sent him off to most probably palliative adjuvant therapy. In Pakistan, maybe also in Nigeria, the frontline therapy always, and still the belief persists that for pancreatic cancer, surgery is the answer. But this is an example of a recent, landmark editorial and commentary by the Italian team. And they have summed up from previous 5 or 6 studies also that neoadjuvant chemotherapy does have a role, that you give chemotherapy first and you make them either you make the tumor smaller or more easily resectable. This is especially for borderline cases, or even for straightforward resectable cases, because it's believed that to begin with, pancreatic cancer may be metastatic, is a metastatic disease. So you improve survival by giving them neoadjuvant therapy first and then operating on them. And we have no experience with this. We have no data on this. So, but we are looking at this very closely because especially with the onset of the pandemic, and now we are forced to look at other therapies where we cannot immediately perform operations. This is especially true for borderline resectables, with people with very high preoperative CA19, 99 levels, or maybe some problems with their fitness at that time or additional comorbidities, and they cannot have such a huge procedure immediately. So there are various reasons, but we are strongly considering neoadjuvant. As you saw on the previous slide, we are already sending them. This is another patient that I wanted to show you. This lady was operated during the pandemic. Again, borderline resectable pancreatic body, body and tail lesion. And I was sure, discussed with a lot of radiologists. We did 3D reconstructions also. Finally went ahead with the upfront surgery. And I thought that the left renal vein may be involved. It wasn't. So as you can see in this diagram, that's the left renal vein. What was involved was the left suprarenal. That's the portal vein and the splenic vein tie off. That's the monster. And we took the spleen out and pancreas and divided the head of the pancreas. I normally use a stapler and sometimes a stitch if I can find a duct and tie it off with that to the right side of the portal vein. And that's the monster. 12 lymph nodes, one was positive for pancreatic. It was a pancreatic ductal adenocarcinoma. 1 out of 12 lymph nodes was positive. Now, what Dr. Adeyeye was talking about, this is very, very important, especially in countries like us where diagnostic errors or wrong decisions may be made. That's the importance of using all your diagnostic armamentarium. That's the importance of taking multidisciplinary decisions. We published this in a local journal, a series of 11 patients who had cystic neoplasms of the pancreas and who were mistaken for ordinary pseudocysts of the pancreas. You know, the treatment for people who are not doctors, the treatment for a pseudocyst, which is not cancer, is a drainage procedure. You drain the cyst into the stomach or the small bowel or anywhere that you can. And but for a cystic neoplasm, which is likely to be cancer also, it has got to be removed. It has to be surgically resected. You cannot do a drainage procedure on a cystic neoplasm. You will never get away with it. It will show up somewhere. It is going to harm your patient. So 11 patients, and some of them had drainage procedures, some had multiple aspirations, and these nil people were being planned for drainage procedures and they were rescued. And as an example, this young lady, she came to us for the repair. You can see on her CT the ventral incisional hernia. She had been operated about 6 to 8 months back, and cystogegenostomy. The primary surgeon in the district said that he had done a cystogegenostomy on a pseudocyst of the pancreas, and now she had a recurrent hernia. Can you finally do a mesh repair? So when we looked at the CT, we got suspicious. We did a CT and we got suspicious because of the irregular outlines and the failure to resolve after cystogastrectomy. No previous gallstones, which is the commonest cause of pseudocyst pancreatitis and pseudocyst formation in our country. Alcohol is rare over here. So we suspected neoplasm, and we did an endoscopic ultrasound biopsy which showed high levels of mucin, CEA and CA19 point levels, and atypical cells were not helpful in this, but mucin levels were high. So we went in for a planned resection. You can see that cyst over there and this bowel which is attached to it by the surgeon probably. Okay, so that's a tumor. We took down the bowel and anastomosed it with a wide margin. That's the monster showing up, and that's, you see, we did a distal pancreatectomy. That's the monster. Now, what's the problem? 6 months down the line, previous surgery, he opened up a tumor, did a tumorogegenostomy. He upstaged the tumor. I opened this patient up. I took down that anastomosis or whatever, and I must have spilled a lot of things over there, and I further upstaged the tumor. And the histopathology, report came out to be an adenocarcinoma. It was malignant. And she had 4 out of 16 lymph nodes positive on this thing. So that's the pancreatic head, and the neck has been divided to the right side of the portal vein. That's the portal vein, right? Okay, so that's the excised specimen, and 4 out of 16 lymph nodes positive. So what do you do? Do lymph nodes make a difference here? This disease is already upstate, opened up twice, tumor spilled all over. This patient had been operated in another tertiary hospital, and this patient was referred to us because they had opened her up and they had closed her down because, and then we did a CT and we thought that this was borderline resectable. And we did an EUS ultrasound, and according to CT criteria, we thought this was a cystic neoplasm, and we had no evidence of malignancy in tumor markers or in the endoscopic ultrasound biopsy aspirate. So that's the monster. A pancreatic duodenectomy was done, and this turned out to be happily a serious cyst adenoma, benign lesion of the pancreas. So we were happy to get rid of it. It could have been cancer, but it did not turn out to be cancer. This is another one patient already aspirated twice or thrice in the UAE and planned for a cystogastroscopy there, but this turned out to be tumor also. So I'm not going to spend time on this. We did a spleen preserving distal pancreatectomy because we were sure that we had done an EUS biopsy and markers, etc. We were pretty reasonably happy that this was not cancer. So we preserved the spleen and we did a distal pancreatectomy. That's the specimen which has been removed from the main specimen. Okay, this is another one. I'll skip over this. This patient, this is the last patient I have to show this one. This is a cystic neoplasm of the pancreas, young female, ECOG 1. And when we operated on her, such a superficial lesion, and I was tempted, why do a distal pancreatectomy? So I made a mistake here. I will tell you why I made a mistake. I enucleated the lesion. And as you can see, that's the enucleated area. That's the head of the pancreas. That's not the portal vein, by the way. That's not divided. And we could not, we thought that we had not injured or divided the main duct also. And that's the thing, enucleation. Now, why not enucleation? Number one, it could still be cancer. You enucleate, then what are you going to do? That's a problem. And this is the only patient out of the whole series which was a mortality. She died 5 days later in the ICU with severe acute portal vein thrombosis secondary to massive portal vein post-operative pancreatitis. I think a resection would be. I mean, we recommend resection, either a distal pancreatectomy or a formal resection. Enucleations are not a good idea, and for the previous reason also. So make sure what you are dealing with. Do not do a drainage procedure on a tumor. Suspect always. Now I've become too suspicious actually, but I use all my diagnostic armamentarium. Enucleation should not be done. Resection should be done. Okay, last 2-3 slides. Screening. Somebody was talking about screening, early detection. Screening and early detection are not our problems in Pakistan. We are up to our heads dealing with advanced cancers. So I think the way forward may be early detection and early and screening, but not at this stage. Palliative care. Now, interestingly, in this region of the world, we are the largest poppy producers in the world. We grow beautiful flowers, but we cannot provide proper palliative care or even analgesia. The old morphine or pethidine that we used to get to all the government hospitals is no longer there. So, and there are no formal arrangements for palliative care, and not in my hospital at least. And there is a new private hospital, cancer dedicated hospital, which has come out in the open, and they are now offering palliative care services also. We do have an associated pain clinic attached with us, and we provide some palliative care, but we don't have formal palliative care services, which need to be developed in the future. Oh, by the way, that's a picture of my chief resident. He's rushing down to the anesthesia department to discuss tomorrow's list. Anesthesia is very reluctant about anesthetizing patients these days. So I think that's the last slide. That's my chief resident, and that these are two senior registrars, and these are the team leaders. The key to success in pancreatic cancer or whatever cancer you're dealing with is a highly motivated, dedicated team, and that's me, by the way, behind the scrub nurse over there hiding. So I think I'll end over here. I'll stop, and I would. Uh, Focus more on team dedication and multidisciplinary decisions. And then, despite the COVID epidemic, I think not delaying upfront surgeries or primary surgeries if they are indicated. However, wherever neoadjuvant bridges can be established safely, they should be done. Thank you very much.
So much, Professor Harold Javid Majid. Thank you so much for the beautiful presentation. There are so many questions here for you and Dr. Adeyeye. So I'll round over to Dr. Adeyeye now to moderate the question and answer time. And in the time being, in case any of the participants has a question, please signify by the sticker raise of hand so that we can allow you to unmute yourself. Thank you so much, sir. So on to Dr.
Thank you.
All right, sir.
Thank you so much for sharing your experience with us. We are so grateful for all that you've done and to make this webinar so successful. At the time, we had a peak of about 171 participants, and everybody has been patient enough. We spent over an hour so far in this discussion. So my take on all of this, based on the questions, I'll read them out. There are some questions that are addressed to me. I think there are some questions that are specific to both of us. So the first question that we have here is asking about screening, and why is it that we're not using tumor markers for screening, and especially when we consider tumors like prostate cancer, where we use PSA as some form of modality. So first of all, the challenge we have, my own take is about it, that the challenge we have first of all is that not all pancreatic cancers produce the common tumor markers of CA19-9, and so it's not every patient that we see with pancreatic cancer that will secrete these tumors. Second point we have is that a patient who has jaundice, a patient of jaundice, tends to have a falsely elevated CA19-9. So it's not a good marker to determine the activity of disease when a parent is jaundiced. It's really more reliable when jaundice has resolved. And so it's not the best of tools to use in terms of monitoring or screening patients. Where it's important is if a parent who does not have jaundice and has a baseline elevated CA19-9 or any other tumor marker, by the time you now continue treatment, you can monitor that serially to see if that becomes elevated or not. We know again that the high tumor marker levels may be a sign of metastatic disease in a lot of patients, but it's not uniform for everybody like for PSA. There's another, I know Professor Majid may have questions on that or comments on that, Susan.
Okay, yeah, thank you. Thank you, Dr. Adeyeye. I feel I've already expressed my opinion about screening at this stage in our own country. However, looking towards the future, I think that CA19.9 would be not a very reliable marker or index because because you said that it can be raised in other conditions also, and on the other hand you have a lot of pancreatic cancer where the CA19.9 is not raised, so the reliability is not there. So possibly, I don't know, you can't do it's not cost effective, and neither is it safe to do imaging based on CTs and things like that. It depends entirely on the population or the load of the cancer in your area. As I showed you in my pie chart, the commonest, it's not the commonest cancer, so it stands at about 4th or 5th at this point. and breast and colorectal are far ahead of it. So we have to look at it cost effectiveness also. But again, ultrasound is an operator dependent thing, and you could maybe consider ultrasound, only ultrasound, but in well-trained, good hands. If you have an HPB, dedicated HPB clinic, and you are a trained man doing ultrasound over there, and maybe that could help. And other possible tools would be too invasive, and or not be cost effective to the general population.
Thank you very much, sir. I totally agree with you. There's another question about asking, somebody asking about the chances of survival in a parent who has background diabetes mellitus and has pancreatic cancer. What are the chances of survival? Well, we know that diabetes mellitus is a very serious condition, and if it's uncontrolled, the patient is at high risk of morbidity or mortality after surgery. But again, it depends on the level of control. For patients who are well controlled, the operative risk is much reduced. It's there, but it's not as much as people who are uncontrolled. And then we know that with the certain patients who have diabetes mellitus of late onset, which actually turned out to be pancreatic cancer. So again, that's one thing that we always tend to exclude in the patient who comes to a pancreatic cancer. They may have diabetes mellitus as a coexisting manifestation of disease. So again, we are very careful about diabetic patients when they come with pancreatic cancers. And somebody asked a question about radiotherapy after pancreatic cancer we experience. Again, like I highlighted in the presentation, is most of the series coming for radiotherapy in pancreatic cancer come from the United States, where they do a lot of chemoradiotherapy as part of the neoadjuvant treatment for the patients. It's very difficult to irradiate the abdomen when the patient has pancreatic tumor, where bowel is there that can be injured by radiation necrosis. And so typically, it's not a popular modality of treatment, but I know there are some of our colleagues in other continents who really subscribe to doing this, especially for aggressive disease. Somebody asked a question about the size of tumor and the risk of spread. Again, I cannot quote the direct article, but I'm aware that there are some studies that have said that a parent who has a pancreatic tumor of more than 2 centimeters in size has a high chance of either local invasion or metastasis. And Professor Majid has already alluded to the fact that many people regard pancreatic tumor as being metastatic at the onset. So one of the issues we are having is that unlike the Western countries, where anybody who has some abdominal complaint has abdominal CT scan or MRI, they are able to detect pre-malignant or precancerous pancreatic tumors and are able to resect that. Unfortunately, we tend in our own settings to see patients with advanced disease who are already growing. So it becomes quite difficult to talk about local disease in reality when most of them are already metastatic ab initio. So, but I think 2 centimeters used to be a cutoff mark. I don't know if Professor Majid has any opinion on the size. If there's any particular cutoff.
Thank you, Dr. Adi. I would like to comment on this. One, it comes to mind that the smaller the tumor, say less than 2 centimeters, and upfront surgery, but keep in mind that even these are known to have metastasis. Because we said in the beginning that this is a naughty disease. That's why people are talking about neoadjuvant. They are having a very low threshold for neoadjuvant therapy because the tumor may be, 2 to 3 centimeter or even less than 2 centimeter. But people, left to me, smaller tumor, I would go for upfront surgery. But I would say, everybody, without exception, 1 centimeter tumor, 2 centimeter tumor, big ones, everybody is going to get referred for chemotherapy because even smaller tumors may have metastatic disease. So everybody's getting adjuvant. Neoadjuvant you can think about, and yes, smaller tumors can have metastasis. It's similar to the disease of breast cancer. It's similar to if you remember the term of early simulating advanced gastric cancer. That's the smaller looking lesion, the Japanese, and the earlier edition of Kusheri has described it. So I think that thing exists over here also.
Thank you very much, sir. There was a question on the first case I presented. What was the time interval between the patient's bypass and subsequent survivorship, that his parents still alive? That's how I paraphrase the question. So the patient had his surgery about 4 months ago, just at the beginning of the pandemic, and has already had 3 cycles of chemotherapy, and is alive, is doing well, even though it was stage 4 disease. So it's one of the patients who were able to help so far. Doesn't have any features of jaundice. There was a question that came in that can we use CA19-9 to differentiate between a pancreatic pseudocyst and a patient who has pancreatic cancer. So again, I know that there are some established guidelines like the Sendai guideline or protocol where you could actually do an endoscopic ultrasound guided aspiration or biopsy of the cyst of the wall and find out whether there are certain characteristics that suggest a tumor or not. So like we said over and over again, C99 is not a good modality for screening or early detection. It's probably most suited for monitoring the patient who has baseline elevated values. I don't know what your take is about that, Professor Majid.
Yes, absolutely. I agree, Dr. Adeye, perfectly described by yourself. I think it can be a benign pseudocyst with elevated CA19.9 levels, and it may be a very, very nasty cancer and no elevated levels of CA19.9. That's why I also emphasize that we must utilize all our senses, and we must be suspicious, and we must use all our armamentarium, whatever guns and machine guns we have. And the best one, I think, is a good MDT meeting with a good radiologist. Look at the CT findings, the irregular walls, or if you think it's suspicious. Look at the history, go back, look at the history. Did this patient have a bout of pancreatitis? No. Does she have gallstones which gave her the pancreatitis? You can still have no gallstones, no alcohol, and a bit of pancreatitis. Remember the peritumor zone of pancreatitis. Some tumors may present as pancreatitis. So anybody who comes to my unit with pancreatitis and does not have gallstones, which is the commonest official cause of pancreatitis in my country, and does not have them, will get a CT scan and will get imaging later on to make sure that we are not missing a tumor. And I think the most useful thing, when you have a cystic thing over there, do an endoscopic ultrasound and aspirate. And look for 3 important things. The least important is the cytology, atypical cells. That's the most leading. You will almost never find them. Look at the CA19.9 levels, not in the blood, but in the fluid, which is aspirated from them. But
Yes.
most important, look at the mucin.
Seen.
The cystic neoplasms, the mucin producing ones are likely to be malignant and need to be resected.
Thank you very much, sir, for paraphrasing the Sendai protocols. That was quite insightful. Now, there are some questions that I think they are more directed to you than to myself, but I'll still give them to you, sir. Somebody sent me a private chat to find out if you can get your slides. So I'm making that open. And the person also said that he liked your ending with the car racing and yes, that was a very hilarious ending.
Dr. Adeye,
Yes, sir.
we have got to break the hierarchical barriers.
Yes.
We've got to listen to our juniors.
Yes,
if
sir.
my junior registrar calls me tonight and tells me that the major gastrectomy you did yesterday, the radical one, he's got a tachycardia, I've got to listen to him. I can't say it's pain only. I've got to listen to him. Only then complications will be prevented.
True.
That's how accidents are prevented. So I think that good motivated teams are the most important thing. You've got to bring them forward. You've got to build leaders. You can't have a couple of soldiers around you fighting for you, but you've got to build leaders for the future. You've got to train them. Now I'm from the old generation. I'm not too good with the laparoscope, but my boys will get all opportunities wherever they can go to learn the laparoscope. Thank you.
So yes, sir. So there's a question that was directed to you that what are your strategies for those missing patients? Those missing patients who had treatments, jaundice resolved and they disappeared. What do you plan to do about them?
Those patients who have received a plastic stent, you mean?
Yes, and then jaundice resolved.
Jaundice resolved. Normally, if I think that the disease is clearly resectable or borderline resectable, but the bilirubin is too high. My criteria is somewhere between 15 milligram per deciliter and above. Say you described a patient with 21 or 25 bilirubin. I would do a direct operation on them. I'll ask for a plastic stent beforehand. And although I don't like the plastic stand because of the fibrosis and adhesions. It makes dissection more difficult. I would love to do a Whipple with no plastic stand. The planes are easier and the surgery is easier. But in the interest of the safety of the patient, to correct the coagulopathies, to prevent the encephalopathy, you have to bring the jaundice down to safer levels. I think if neoadjuvant chemotherapy is not involved, if you're planning an upfront operation and you've asked for a plastic stand to optimize the patient, to improve renal function, to improve sensorium or encephalopathy and coagulopathy and things like that, then a good time would be to operate between after the stent 3 to 5 weeks down the line, when the liver has recovered and the liver function tests, although may not have returned to entirely normal, but they're closer to very low limits. And you have a patient who's walking around, climbing stairs, and I mean, I would see the patient then. But generally, the time would be after 3 weeks.
Yeah, thank you, sir. And that takes me to my next question, because in Nigeria, we have very limited access to endoscopic therapies. Probably only 2 or 3 centers are doing ERCPs actively. That was even pre-COVID. And probably now, post-COVID, probably 1 or 2. And so many of our surgeons are not able to refer patients for ERCP and that kind of stents. So somebody has asked a question that, can we do a stage procedure, do a biliary bypass, and then allow all of this?
You mean do a surgical bypass?
Do a surgical bypass as one stage, and then resect at a later stage.
Yes, that's quite possible, but then to that is added the morbidity of an operation, because this patient is going to be deeply jaundiced, and the problems of infection, coagulopathy, hepatorenal syndrome, encephalopathy, these are all there. So he'll be subject to an operation. It's preferable that you have stenting, but if you don't have it, and the other thing, you do a good bypass and the patient settles down, abdominal re-entry is of course going to be a difficult operation. Yeah. So that will be again a difficult operation. It's not that it cannot be done, because we have ERCP and percutaneous transhepatic biliary stenting services. So we are generally not doing this, that do a bypass and then go back in for a resection. That's not the norm. But it's not that it's not possible. It's quite possible. And if at all, my advice to you, if at all you were planning to do a bypass because of that reason, that you're planning to do a bypass now and resect this patient, say 5 weeks down the line or 3 months down the line, plus minus neoadjuvant, then do the minimum dissection in there. Then, so that your planes are good, your planes are still virgin when you're mobilizing. Do not expect to do a trial dissection of the portal vein and then abandoning it and then doing a bypass, then giving neoadjuvant and then expecting to resect it. Don't destroy the planes then.
Yes. Yeah, I understand. So again, another question on surgical technique is that, do you routinely biopsy your pancreas in a patient who wants to do a bypass procedure for? Do you routinely do pancreatic biopsy for histology? And then do you routinely do celiac plexus block for those patients?
Not every time. If you have a lesion over there in the head of the pancreas, it is malignant until proven otherwise. If you have that kind of a lesion on CT criteria and on endoscopic ultrasound evaluation, you could have done a biopsy then. However, biopsies are not always essential. Sometimes you don't have biopsy, despite ERCP efforts, despite endoscopic ultrasound, you don't get anything. You get a negative result. You have jaundice, you have a hypoechoic lesion there in the head of the pancreas. You do an endoscopic ultrasound biopsy, it's negative. What does that mean? It's not cancer. It could still be cancer. So I think a lot of the pancreatic resections which look like cancer, you can go ahead with pancreatic duodenectomy after optimizing the patient. Sometimes it happens that you think it's cancer, you resect, and it comes out to be, for example, chronic pancreatitis. But then again, chronic pancreatitis is also such a destructive disease that sometimes you do have to do a pancreatic duodenectomy for chronic pancreatitis also. So what's wrong with that? So if at all histological diagnosis is possible, you do it. If it's not possible, you can still operate, giving it the benefit of doubt.
Thank you, sir. Now, a lot of our surgeons here still do cholecystogeginostomy. That's gallbladder to the jejunum, rather than cholecystogeginostomy or hepatocogeginostomy. What's your take about that, sir?
Sir, after 20 years, 3 days, 4 days back, I did a cholecystogeganostomy. This was an advanced gastric cancer patient which was invading the head of the pancreas also. I was forced to operate, and then the tumor was around the distal CBD also, but the patient was not jaundiced, likely to be jaundiced in the near future. So, and I was forced to operate because the patient was bleeding. After every 3 days, the hemoglobin would drop to 6, 7, multiple transfusions, 6, 7. So I did an R2 resection, deep part of the stomach, left the head of the pancreas behind, and wanted to do a hepatocogenostomy, but my friend said, please leave her alone, could do a cholecystogenostomy. The cystic duct seems nice enough. It'll be okay. And she's at this moment not jaundiced. So I did a cholecystogenostomy after 20 years. So for a durable bypass, if you want longer survival and you want delayed return of jaundice, take the gallbladder off, take it out of the way. If it's a good, nice 2.5 center CBD, go higher up, closer to the hilum, open it longitudinally there, and you can extend the incision slightly to the left on the pancreatic duct, on the left hepatic duct. That's the common hepatic duct, cut like this.
Yes.
Left hepatic duct, cut like this, wide stoma. Take the rule loop up and anastomose it there.
Yeah.
And giving the benefit of doubt, if the patient is stable, do a gastrojejenostomy also, do a triple bypass and an enterostomy. So what I'm saying is that the hepatocogenostomy is more durable than a cholecystogenostomy. Cholecystogenostomies may not always work and be very embarrassing.
Thank you very much, sir. So there's another question about how Pakistan has been able to overcome the cost issues with pancreatic resections. That because we have lots of issues with cost, but you've not mentioned cost as a factor here for your patients.
I think the situation over here is exactly the same. The the hospital that I work in has a private wing also, where the patient pays just like a private hospital, and the general wards also. But our general wards are also paid. Also, it is very, very subsidized. But you have patients who cannot afford even that much. And I would say, I would quote Abdul Sattar Idi from Karachi, the saint from there, that and Professor Rizvi from SIUT. We will not let them die because they cannot afford to live. So either beg or borrow or do something or steal. I wouldn't say steal, but I'm sure that a lot of problems can be sorted out. The administrator, if with a nice smile, a nice gift of box of chocolates or a roses for somebody, you can make way for your patient. You are your patient's lawyer. You're your patient's advocate.
Okay.
So sometimes from your own pocket also, maybe, if you can afford it, but depends on your mood. So I think that you do whatever you do. Because they cannot afford to live, you cannot let them die.
That's a very, very strong quote, sir. Thank you so much. I think
we
this
look
is the last
for all
question
government aid, and we try. There are so many philanthropic groups, people giving donations also. So there's a lot of help comes in. So things work out eventually. But you're in trouble when you want to give injections of albumin for 4 or 5 days post-operatively, and then there is no albumin.
Yeah, so we're almost out of time. We spent almost an hour and a half or thereabouts. So I think this is the last question I have here with me, and it's a private chat that you mentioned briefly about anesthesia. Now, in this COVID-19 era, are your anesthetists insisting on viral filters before taking your patients? Because some of our anesthetists are insisting that they have viral filters attached to their anesthetic machines before they anesthetize any patients.
Dr. Adeye, we don't have any biofilters. We have no negative. In the early part of the pandemic, we had to shut down our HVAC system because we thought it would spread the virus all over the hospital. And it was hot, and it was the holy month of Ramadan later on. Fasting, and in that heat, no air conditioning. We used for a couple of days, the old tuberculosis hospital technique of opening the windows, putting 2 big pedestal fans over there and making them blow the air out in the opposite direction. But you see, so where there is so many constraints, the anesthesia teams take all PPE precautions, that they have the best masks. If they don't get them, they buy them or whatever, they get them. they minimize the number of people in there. Normally, I would not let a patient under normal circumstances be anesthetized because without one of my senior residents standing there as
Yes.
witness or to the conduct of the induction of anesthesia, because we've got to know what happened during induction. Now we want lesser people in there. So my spy wears an N95 and goggles and visor and stands in the far corner when the induction is being done. And 2 or 3 anesthesia people there also with full precautions. But obviously, with what kind of filters you're saying, we don't have them. Not in my hospital. Maybe one of the better hospitals may have them.
Thank you very much, sir. I think we have some people who want to make a comment or question. I can see Raza with his hand raised on the chat box. Can the host unmute Raza and allow him to speak and to also see his video?
Hi, thank you very much. This has been a very interesting and insightful talk, both by Adil, Dr. Adil and Professor Majid. I would just like to take this issue forward, which is very sore point for both Nigeria, Pakistan, and in fact for all the lower middle income countries, is that patients generally present with advanced disease. And that means a significantly smaller percentage of these patients will be eligible for surgical resection. However, it is our job to treat all the patients, whatever their appropriate management is. And this brings a little bit of a leadership responsibility on us surgeons who manage these patients. And perhaps it is for us. So for one patient's management, we do not have endoscopic services available. We do not have palliative care available. We beg, borrow, steal, whatever. But for the management of our future patients, because we know the spectrum of disease that we get, we know the kind of presentations that we have, we need to plan a strategy how to improve the services or the quality of services for our future patients. So if I work in a facility which does not have endoscopic stenting available, I need to speak to my hospital. I need to develop a rapport with certain gastroenterologists, endoscopists, and perhaps develop a plan where someone can be sent for training. Some finances can be arranged. I mean, this is a problem for almost every situation, that whether it's in Nigeria or Pakistan, most of the facilities have this problem. So we need to figure out how to improve the care for our patients in future, and for that we need to make a plan. Secondly, just to make a comment for screening, if we look at the figures of Globocan, which provides morbidity and mortality figures pertaining to cancer all over the world, when we look at the most common cancer type resulting in the highest mortality for each country, Pakistan, Africa, some parts of Latin America, the most common cancers causing death in both the countries or in most of the lower middle income countries, you would be surprised, are breast cancer and cervical cancer. Now, these are cancers for which screening has proven to improve outcomes. And so it actually reflects the agony or the irony that we have some resources, but they're not appropriately utilized. So screening is a national strategy always. But unfortunately, probably Professor Majid is right that pancreatic cancer will be low down in the order when we think about screening. Thank you very much. This has been very insightful and a great session. We hope to attend this in future from Pakistan. Thank you.
Thank you, Raza. They were very, very useful comments. And Dr. Adiaye, I think the best time is to start now. Select your men, get them trained in 2 years, 1 year, 2 years, you will be all right. So you start their training now.
Yes, sir.
Sure.
Thank you so much. Thank you so much,
And I would
Raza.
like to thank you, Dr. Adey and Ms. Yemisi Adey, for being the host. I'm sorry I cannot pronounce properly. My English is very heavily accented.
It's
Uh,
okay. Thank you so much, sir.
thank
It's
you.
okay.
So it's
Thank you so much
very
again.
useful. I look forward to meeting you guys again, and I welcome you all to Pakistan when the pandemic is over,
All
and
right.
we will host you over here. And we look forward to meeting you over future webinars also. And it has
All
been a
right.
very useful exchange of ideas, and I think that people who share uh, similar problems and issues, when they talk about it, they can find a way out. Well done, Dr. Eddie.
Yes, sir.
Thank you
Thank you
so
very
much.
much, sir.
Thank you very much.
Thank you very much for the comments. I think
I think we should
we've
say goodbye now,
gone past time.
or are there further comments?
Yes, we say goodbye now. So the host over to the host to round up the meeting so that we can all depart.
All right. Thank you so much. Thank you so much, Professor Harun Javad Majid. Thank you, Dr. Adeyeye, for the beautiful presentations too, and the question and answer time. I want to believe that all participants were able to get useful information for future use. And it will be a pleasure to invite you once again, sometimes very soon. We hope to do this maybe like twice a month, and we'd like to invite you when it's time. So thank you so much for being so patient and participating in this presentation of pancreatic cancer. And want to say thank you so much to you. Thank you.